Welcome to today's webinar, Lessons Learned from the First Wave of COVID-19, How to Navigate the Second Wave and Implement Lasting Changes to Benefit Your Practice. Today's speakers include Frier Levitt Healthcare Partners, Arielle Miliambro and Guillermo Beades, and Healthcare Compliance Networks, Wiks, Moffat, and Jim Tudor. Before we get started, I just wanted to note that all lines have been muted. We hope that you enjoy this program, and without further ado, Mr. Moffat is going to get us started.
Lauren, thanks for Frier Levitt and you for organizing this webinar. And the first one, I'll kind of take them in order here. Telehealth usage increased drastically as a result of COVID. There's no question that it has. I mean, COVID has completely turbocharged telehealth. And I'm not going off any real data here. It's kind of, we work with thousands of medical practices, and this is just what we're seeing and the questions we're getting and all of that. And hopefully we'll go through some of that on this webinar. We, just as quick background, we've been involved in telemedicine, probably for 10 years or more. We were very actively involved with the American Telemedicine Association, and we're one of the first groups to be accredited to accredit physician practices for telemedicine. And it was an effort called CHQI, which is Clear Health Quality Institute. They've since been acquired by NCQA and they've gone a different direction. But needless to say, we did a deep dive into telemedicine, and I'm lucky that I and my company are I believe, fairly well versed in all of it. Now that NCQA is, we'll see what's going to happen with it. But very quickly, it has completely increased, and it's certainly not going away. It's certainly not just a fad. What's interesting, and again, this is more of a man on the street perspective, we work with one of the largest primary care practices in New Jersey. They've got over 50 providers and a few hundred employees. And what I found interesting that I've heard from them is everybody, when this came out, said, oh, you know, the seniors, the Medicare population, the older population is not really going to embrace telemedicine. And they use the majority of our healthcare, or a lot, for obvious reasons. And what's kind of interesting is that the older population, the Medicare population, from what we've seen, has actually embraced it. They don't have to get a caregiver, a son, a daughter, a spouse to get in the car, you know, shovel the driveway and get out to their meeting or their appointment. Now they can just dial in and there they have it. And it doesn't always have to be video telemedicine, obviously. So again, I guess I'm just reiterating, this is not a fad. It is not going anywhere. It's only going to increase. And now with the addition of all the remote patient monitoring devices that they have out there, I'm not just talking about blood pressure cuffs and things like that. They're getting even more and more sophisticated. And that segment of the industry I see only expanding as well. And with chronic care management, you know, they're calling the patient several times a week to make sure that they make their appointments, to make sure that they've taken their medications, to see if they need any help. So it also blends very well into all the value-based care that everybody is pushing. So telemedicine is going to be a very integral part to every piece of healthcare going forward. Compliance, of course, plays a really big piece in this. And whenever I'm talking about it, which obviously is now, I always say your two biggest areas of risk with regards to telemedicine are sort of your two most valuable commodities that you have. And if you think about it, in a healthcare organization, your most valuable commodities that you have are all of the data that you have the patient's protected health information, the PHI, the EP, the electronic protected health information. All of that is one of your biggest assets, and you've really got to make sure you're buttoned up very well on how you're protecting that. Have you written up your program, your policies and procedures? Have you trained your employees and all of that? The other big compliance issue and is all the billing. That's where the money is, right? And New Jersey, I believe this is mostly New Jersey, but basically every state in the country now has what's called parity, which means that you can bill the same amount for a telemedicine visit that you can for an on-site visit. So that's good news for all of the providers out there, that you will be reimbursed the same amount. Obviously, there's certain things that you can't do and certain limitations with telemedicine visits, which I think are rather obvious. But the other thing that's going on right now that I think is, well, I know for a fact is not going to be here forever, and it's the waiver 1135, which simply put has said you really don't have to comply with all of these very strenuous regulations. You can do FaceTime for an appointment. You can just do a regular landline telemedicine appointment. They have removed all the barriers because of the public health emergency, so everybody could get widespread access without all of the hurdles that are in place. That party is going to be over pretty soon. I don't know when, but when it is, you're going to really need to have your program well in place. So now is the time to, if you haven't done it, or if you have done it, really review your program, see that it's buttoned up, because the party's going to be over soon, and you can kind of do a dress rehearsal and mess up. Now, I use the analogy, may not be the best one, but of a Broadway play. They do their dress rehearsals, they can fall off the stage, they can miss a line because it's a dress rehearsal. No harm, no foul. Well, when that's going to end, I don't know. And the next piece is implementation, which hopefully is a good segue into our friend Arielle, who can talk a little bit about that from the legal side.
Sure. So when we're talking about telehealth, first we have to understand the types of encounters that we're referring to. And for purposes of today, telehealth is the provision of healthcare service by a practitioner who's located at a different site than where the patient is who they're treating. And telehealth can be conducted through various modalities. For example, some states allow remote patient monitoring and asynchronous store and forward encounters, while other states or other circumstances may require live two-way audio-visual video conferencing. So the modality through which telehealth must be delivered is going to be determined based upon the particular state law where the patient is located, the standard of care for the service that's being provided, as well as any applicable payer requirements for that particular beneficiary. So with respect to the challenges to implementing telehealth, one of the first is certainly the limitation that's associated with licensing. In general, telehealth occurs at the site where a patient is located. Therefore, the practitioner must be permitted to render treatment to that patient in that particular state. So most states require licensure in order to render care to patients who are located there, but some are more flexible or may have exceptions to licensure for discrete or infrequent rendering of care, or perhaps they only require notification to the Board of Medical Examiners instead of a formal license application process. Many states have also become temporarily more lenient with licensing requirements as a result of COVID-19, but with the rest of COVID waivers, these changes are only intended to be temporary. And each state also navigates these waivers differently. So in some jurisdictions, if a provider is licensed in a neighboring state, they may be able to render care to patients in that state. In others, perhaps a provider may be able to render care for a limited amount of time, like 30 days, but they can only do so after providing notice to the board, and they can only do so for patients who they've established existing relationships with, who have then relocated. So each state's licensing requirements, both before and as a result of COVID, have to be evaluated prior to delivering care into a particular jurisdiction. Another challenge with respect to implementing telehealth is creating a bona fide relationship with a patient and engaging in a bona fide telehealth encounter. So that's not only necessary for purposes of compliance with a licensing board regulation, but it'll also have a direct impact on whether the encounter is reimbursable, and as well as whether a prescription order that results from the encounter is valid. Different states have nuanced requirements for establishing a bona fide telehealth encounter, and these requirements can be based on a number of different factors, including the type of modality that the provider is using, whether certain disclosures are made to the patient, if the provider is properly documenting the encounter, whether they've obtained consent specifically to provide telehealth, and whether the standard of care was reasonably met through that virtual encounter. So if an encounter is not bona fide from a licensing board perspective, payers can use that as a basis to impose recoupment, but the provider can also be subject to discipline, obviously, from his or her licensing board. Another challenge is related to reimbursement. And the reimbursement guidelines for telehealth will necessarily depend on which payer is at issue. So CMS, for example, has very restrictive requirements in order to obtain payment. And as Wiks touched on, there are waivers, but outside of those waivers, one of these requirements has to do with an originating site. And an originating site is where a patient is located at the time of an encounter. And pursuant to Medicare reimbursement guidelines, the originating site has to be outside of a metropolitan statistical area or within a rural health professional shortage area. And in addition to that, it has to be at the office of another practitioner or physician, or a hospital or a rural health clinic, federally qualified health centers. There's a number of different offices where the patient can be located, but ultimately this is an exhaustive list, and it's limited. So the patient can't be in their home or at a park or something like that. They have to be essentially with another provider at one of these designated facilities. CMS also limits the types of services that can be rendered through telehealth. And as a result of COVID-19, there are many expansions to the reimbursable services that are covered, as well as the waiver of those originating site requirements that I mentioned. So during the public health emergency, patients were and continue to be permitted to be in their homes during an encounter. As Wiks mentioned, it's unclear when that waiver will expire. I've seen that it's expected to last at least through the end of the year, but there's really no telling. There was legislation introduced last summer called the Protecting Access to Post-COVID-19 Telehealth Act, and that sought to permanently remove the originating site limitations for reimbursable encounters, but until that's enacted, that's just pending legislation. So unless it's enacted, when the 1135 waivers expire, the more restrictive limitations related to Medicare reimbursement will be activated again. Aside from Medicare, there's also Parity Laws, which are state laws that require payment for telehealth services. With respect to Medicaid programs, all 50 states and DC reimburse for some form of live audio-video telehealth service. 21 programs reimburse for remote patient monitoring, and 18 Medicaid programs will reimburse for store and forward. Separate from that, there's also private payer parity laws. And 43 states have some law that touches on private payer reimbursement. And some of those require reimbursement at the same level as if the encounter were conducted in person, but most just require some form of coverage for similar services, not necessarily in the same amount. So common limitations in payer policies are going to relate to the specialty that the telehealth service can be provided for, the types of CPT codes that are going to be reimbursed, the types of providers who can actually render the care and be reimbursed, and less so with COVID, but pre-COVID, the location of the patient. An additional challenge is going to be the technology adoption and ensuring that your practice implements appropriate technology and has proper training on that technology is going to be critical to the success of any telehealth program that a practice implements. So the technology that you choose has to be user-friendly from the patient's perspective as well, because if a patient can't interact with that technology appropriately, it can interfere with creating a bona fide relationship with that patient or otherwise engaging in a valid telehealth encounter if a video encounter is required, for example, and the patient can't connect to the video. So typically all telehealth technologies would need to be HIPAA compliant, which requires significant security features and also would require providers to have a business associate agreement with the technology provider that's providing service to them. But again, due to COVID-19, OCR, which is the agency responsible for enforcing HIPAA, has announced that it would use its enforcement discretion when it comes to telehealth technology. And the purpose there is to ensure that HIPAA's impact on technology wouldn't be an impediment to delivering care during the public health emergency. And in this enforcement discretion notice, it basically, OCR has given guidance that any non-public facing technology application would be appropriate for use. And again, like the other waivers, this is not permanent. And frankly, practices at this point should be converting to or reviewing a more secure and appropriate technology for use in the long term, rather than continuing to use applications like FaceTime or Zoom. In addition to these challenges, providers must also be aware of the general regulatory compliance of any telehealth arrangement that they're entering. So adding telehealth as a service for an existing practice aimed at providing care to existing patients typically is going to present a more limited risk than entering a sort of on-call type telehealth relationship where the provider signs up to render care on behalf of another entity in exchange for a payment per encounter or similar terms. And while many arrangements appear to present the opportunity for a physician or provider to expand the reach of their services, these models in general are rife with risk. So prior to entering or developing a telehealth model, it's important to understand the implications on federal and state kickback and self-referral prohibitions, as well as fee splitting prohibitions, among other areas of concern. A very common but impermissible arrangement in telehealth is one where a provider is compensated by a telehealth company for his or her professional services. And the issue is that the telehealth company generally obtains the funds to pay the provider from either a marketing company on behalf of an ancillary provider, like a pharmacy or a lab, or by the ancillary provider directly. And at the conclusion of the encounter, if a prescription is issued, it's submitted to the ancillary provider whose payment was used to compensate the physician. So basically you have an ancillary provider indirectly paying a physician, and in exchange, they receive a prescription. And then the ancillary provider bills the patient's insurer. So this implicates many federal and state healthcare laws, and it's a model that's commonly audited by payers, but it's also a model that's commonly prosecuted. And we've seen providers ordering privileges get revoked for models similar to this. And many times the provider is terminated by Medicare simply for failure to submit a claim for payment for their physician encounter, which is mandatory pursuant to participating provider agreements. So this is generally discovered when CMS contractors attempt to reconcile pharmacy claims with encounter claims, and they're unable to do so because the encounter hasn't been billed. So in general, all stakeholders just really need to remain aware of the totality of the telehealth model that they're participating in to properly evaluate their exposure. Next slide, please. So in addition to the challenges to implementing telehealth, there's also certain limitations. So with respect to prescribing, state law generally governs the ability of a physician to appropriately prescribe medication to or treatment to a patient. And some states will limit the types of medications that can be prescribed if the physician-patient relationship has been formed and the encounter has been conducted by way of telehealth. So for example, if a physician fills out, if a patient fills out an online questionnaire that's reviewed by a provider and the patient and provider have no other contact with one another, the questionnaire is likely insufficient in the vast majority of states to establish a bona fide physician-patient relationship and thus prescribe medication. So if a prescription were issued based on only an online questionnaire, that prescription would then be considered invalid. And this could be discovered during an audit of the ancillary provider who's submitted a claim for that prescription. And as I mentioned, we've seen those audits result in revocation of ordering privileges for prescribers, but it can also lead to more significant investigations of the overall telehealth model. From a federal perspective, there are also limits on the ability to prescribe a controlled substance without first having seen a patient in person. And there are waivers related to the Controlled Substances Act based on COVID-19. But again, that's a temporary waiver, and any provider who intends to prescribe a controlled should be aware of the applicable federal and state laws governing that practice. Another limitation to implementing telehealth is understanding the supervision requirements for mid-level practitioners. So many practitioners may seek to engage a nurse practitioner or a physician assistant to provide telehealth coverage, so to speak, so the physician can continue to render services through their in-person practice while the mid-level practitioner provides telehealth support to the physician's patients virtually. However, physician providers need to be aware of what each state's requirements are with respect to supervision of mid-level practitioners, as well as what their scope of practice will be. For example, there may be requirements that the provider have a written agreement or set of protocols that's executed and kept on file between the parties, or even in some jurisdictions, those agreements or protocols have to be executed and submitted to the state licensing board. So all the practitioners involved, both the physicians and mid-levels, need to be aware of those requirements when they're seeking to supplement their services. And finally, another limitation to telehealth is the standard of care that would be appropriate. So using a telehealth visit rather than a face-to-face encounter doesn't negate any applicable obligation on the provider to conform to the appropriate standard of care. Certain services just won't lend themselves to a telehealth encounter because the physician's unable to examine the patient as would be required for a particular diagnosis or condition. So if a provider would typically need to lay hands on the patient or do other tests that require physical presence, the visit wouldn't be conducive to telehealth. And adherence to the standard of care is particularly important in the telehealth landscape because beyond just audit risk, we anticipate that is likely to be the biggest source of malpractice liability for practitioners. And with that, Jim and Guillermo will pick up from there.
Thanks, Arielle. So, I think it's good to understand, the compliance issues as Arielle described them, and the state of telemedicine now and into the future, as Wiks led us off with. And I think what we'd like to talk to you about with Jim right now is sort of a little more forward leaning, where we talk to you about, well, what can you expect? We all would like to think that payers, be it CMS, be it Horizon NJ Health, or one of the other major carriers here in New Jersey or across the country, would be forgiving, would be understanding of documentation errors and omissions, particularly that happened during COVID. But that just unfortunately hasn't been our experience. Jim and I, HCN and Frier Levitt have been working to defend physicians on post-payment audits, prepayment reviews, every one of the alphabet soup of audits from the CMS, because they're still ongoing. We're in the middle of a pandemic, and you have, SIOCs, on behalf of one of the payers requesting 200 charts. And we're getting those complaints, and we're getting involved in a lot of disputes, and we're seeing, 5, 6, 7-figure demands. We're working on one close to 8-figure demand. I mean, we see large overpayment demands in the midst of COVID. I'm not hopeful that, documentation during COVID is just going to be completely overlooked. One of the things that I think you could take away from this presentation is that while there is this period of leniency, while there still isn't anything that's firmly, written, this is a perfect time for you to get your house in order. I understand there's a lot going on. A lot of practices are going through a lot in light of COVID, but this is a perfect opportunity to, get your ducks in a row, make sure that you're documenting particularly the most used codes in your practice correctly, because we believe that telemedicine is going to be audited. It's just going to be. It's a reality of life. And when they audit, they're going to be looking at certain things, certain areas of weaknesses, certain things that are also generally applicable to all audits, to all documentation issues. And although I'm not a certified professional coder, far from it, having worked with Jim and his team over at HCN, I can talk the talk a little bit now, because I've seen the same issues come up over and over again. And because telemedicine visits are office visits, we're going to see the same type of focus, I believe, on higher level codes, modifier use, things of that nature. Their greatest hits that they always go after. So with that in mind, I'd like to, turn it over to Jim, because one of the first things that I think as a provider, it's an area of frustration. And we've seen this pre-COVID. What happens when there are no guidelines, specific documentation guidelines? We've seen that in the area of, testing for certain things like allergy testing. We've seen that in podiatry with L3000 custom orthotics. What happens when there isn't, a specific guideline, a checklist for you to follow? It's not as simple as, an E&M visit where you have to check off, how many systems you reviewed, the level of medical decision making, how detailed was your history, where it's more nebulous. Unfortunately, it doesn't go into favor of physicians most of the time. It's used as sort of a moving target by providers. So, by payers. So I'd like to turn it over to Jim to maybe talk a little bit first about, if there are no current guidelines, how does that work? And, what's your, suggestion to providers?
Yeah, thank you, Guillermo. So fortunately, what I'm finding so far is that most of the payers do have guidelines pertinent to telehealth. Most of them actually have either a published policy or a memorandum that's easily accessible via the internet. which spells out, what the coverage guidelines are, what modifiers are required, whether or not there's a cost share, and what those considerations may be. There are a few out there that currently don't have anything tangible in place. I mean, maybe they keep that hidden under lock and key, but it's not easily discernible through a Google search. In those instances, you really have no other option than to just straight out defer to the CPT guidelines, to follow all the guidance. There was some guidance given about a year ago from the AMA with regard to certain scenarios and how they're supposed to be billed based on their recommendations. And then, as we would have expected to happen, all the payers ran with it in different directions. And if there's still any doubt regarding a particular situation, after having looked through the CPT guidelines, it's reasonable to follow CMS. That would be a diligent way of expressing a desire to be compliant with, what in many payers, follow CMS guidelines anyway. So I think it's reasonable for any provider to either follow the CPT or CMS, but I would probably start with CPT.
And concerning telehealth visits, when they are, your typical E&M type of visit, maybe not necessarily so much new patient, but a lot of the follow-up patient care, how the new E&M guidelines, how do they apply to this?
Yeah, so there aren't any, as far as, there isn't a telehealth application of E&M coding rules per se. And this was even true last year, where with a couple of exceptions from a documentation perspective, which I'll get to, essentially the provider was to document the encounter in the manner that they normally would. The kicker this year is that there are brand new guidelines which have gone into effect as of January 1st. Those guidelines are, for the most part, a bit more user-friendly than the previous iteration of the CMS guidelines, in the sense that there's a lot more emphasis on time. You can count a lot of additional physician work as time towards your coding that you couldn't in the past. More emphasis on medical decision making as well. There's no need to worry about meeting certain requirements on your history and physical exam anymore. They still want you to document an exam, but only that examination which is most relevant. You need not worry about how many review of systems do I need for a level 4, or body parts in an exam for a level 5, or any of that. It's just document that which is most medically relevant for the care of that patient. So removing those requirements are huge. The medical decision making changed a little bit. There are some instances where maybe you would have had a level 4 in the past, and now you're looking at a 3, or vice versa. It kind of depends on the specialty and the circumstance there, but in general, the early returns that we're getting from our clients on the guidelines is that they are more user-friendly than before, and the physicians seem to like them as much as physicians can like anything related to coding.
And the new guidelines, are they affecting all providers generally the same, or are any providers seeing a disproportionately better result as a result?
So the new guidelines apply only to the office visit codes, the new and established patient office visit codes. So if you're seeing a patient in a skilled nursing facility, or the ED, or the inpatient hospital visit, you still have to defer to the same guidelines you had before, and you still need to meet all the requirements on the history and exam as per before. With regard to office visits, there are no specialty specific E&M guidelines. As many providers were aware, there was a variation of the CMS guidelines that came out in 1997, which was allowed specialty providers a physical examination under the examination grading aspect that was more tailored to their specialty. You don't see anything, you don't see medical decision making for dermatology or orthopedics under the new guidelines. It's very generic. Some folks don't like that aspect to it because we still don't really have much in the way of examples. There are some parenthetical examples in the MDM, but really it's some providers would prefer to have something more tangible you can sink your teeth into. The fact that it's more generic has advantages and disadvantages depending on your perspective.
And since payers seem to treat, from what you're saying, telehealth similar to regular visits, there's no different. There are some different CPT codes, but for the most part, there's a lot of overlap. What are some of the potential areas of weakness that you see now that we're shifting into an audit, let's say, of a practice that has adopted telehealth but now is using it predominantly?
Well, one of the things that I see, and we have been doing some audit work on this, one of the things that we see right off the bat in a note is that it's unclear as to whether or not it was a telehealth encounter or that it was a telehealth encounter involving video. According to the CMS rules, and I think in general, most payers follow the CMS on this aspect. In order to bill an E&M office visit code, there must be use of video technology. A phone call is billed using an entirely different CPT code set. So if you don't make it clear right off the bat in your note that it was a video encounter, then it's the guesswork begins. And typically, as the golden rule of coding goes, not documented, not done. If it can't be determined that there was video technology used for that particular visit, it can and will get dinged in the event of an audit. The other thing that Medicare wants, and again, I think there's general consensus from the payers on this as well, is that they want the provider and the patient's location to be documented during the encounter. So we often see the most common scenario is we see that the provider mentions the location of the patient, but fails to mention where they are. Under the telehealth liberties under the PHE, the provider can be located virtually anywhere until the new normal takes shape. And they really want the provider to mention that in their note, whether you're in the office, whether you're at home, they want you to be very specific. And then the third aspect of it is the names of any individuals who may have participated in the encounter. Usually that would entail someone who's with the patient, a spouse, or someone who's contributing to the history. In a pediatric scenario, usually the parent, of course. And the other thing that we find is that there's still some confusion about billing the E&M code for a phone call. In the very beginning, CMS had implied that that would be acceptable, and there was some flip-flopping on that. AMA implied that it was possible to bill just a straight phone call using an E&M code. And then around a year ago, Medicare made clear that they expect video to be used for billing an office evaluation and management service. And without it, it absolutely can't be billed as an E&M. And we're finding that some providers are still billing for phone calls using the regular E&M codes instead of the phone call codes, which are, as I mentioned earlier, an entirely different code set. So those are probably the weak spots, and of course there's, ways that the providers, that the payers are monitoring this, and audit activity can occur usually, due to overutilization, where there's things like impossible days. All the codes have a typical time associated with it. And if you build too many of them, it looks like you build for a 32-hour day. Well, the same principle applies to telemedicine as well. And the telemedicine encounters can get flagged by use of the two modifiers, the 95 modifier and the GT modifier. So if you're billing for a 28-hour day using the GT, you could get in some hot water for, right off the bat for presumed misuse of the codes. Whether or not that actually would hold in the event of an audit depends on many, many factors. But the bottom line is to try to avoid audits to whatever extent possible. Excessive volume, failure to comply with the payer requirements. If you're consistently billing the wrong modifier, the wrong code, in other words, the payer wants a modifier 95 and you're billing it with the GT, even though that's a revenue neutral type of scenario, i.e. it doesn't result in the practice getting paid anything they weren't entitled to, it still infers that the group may not have a tight handle on their billing and coding, and it would get flagged in as an error. And if there are too many errors, it really opens up the doors for them to step in and do a record review. And in the future, I think, and Arielle had mentioned standard of care, how there'll be more emphasis on that. And there will be ways that the coding can trigger audits, specifically ICD-10 diagnoses, which are usually associated with conditions that for which standard of care is typically not met or has a lower frequency of being met via telehealth. I can see once things take shape, there's built into payer policies for telehealth, we're going to get standard of care, frequency limitations, and things along those lines. So from the 50,000 foot view, Guillermo, that's where I see things, where the weak spots are, and what can open the floodgates.
Thanks, Jim. And just one more question that I would have for you is, since you and Wiks, I know, have spoken to a lot of providers about implementing telemedicine and the related I guess challenges. One of the things that I understand, this is also just from working with attorneys as well, who are, I'm going to say, of a certain maturity. Sometimes they say, well, listen, I'm not tech savvy. Like, how am I supposed to implement this? Or, how big of a barrier of entry have you seen it be when someone is not necessarily, millennial, tech savvy, and, born with an iPad in their lap?
Yeah, I mean, perhaps Wiks can expand on this as well, but, I think the number one thing is to make sure that, some of these systems are just abundantly simple to use. And I think often if the physician objects to telemedicine on that basis, they just need someone to sit with them and explain, really we're talking about things that are not really much more complicated than Skype and FaceTime, which are abundantly simple to use. And they just need it explained to them, how it works. And also they may need to reach out to their patients to provide some level of assurance there, as far as those, as Wiks, I believe, mentioned earlier, we're finding that, there's a pretty significant percentage of seniors that actually like telehealth, whereas, we thought in the beginning it was going to be something that, was foreign technology that they would object to and they're not comfortable with. And, I prefer to see the patient in person. But I think that, there's still, we're finding some that being more accepted than was anticipated, but there are still some patients that do object. It's going to be a big year for telehealth, and it's going to continue to grow. Probably, I read a survey where it said, or a study where it says, probably we're looking at 20% of all medical visits being telehealth encounters in 2021, to the tune of $30 billion. So it's only going to increase. And I think that just right at this point, once the security considerations become more robust, that'll be another thing. But right now, it's just making everyone aware of really how simple the technology is to use in general.
Hey, Jim, good point. And I think there's your answer to, is this a fad? What did you say, 20% in 2021 is going to, I mean, or 70 billion. both really big numbers, obviously. But I would say, as you're trying to do this, or if you're already doing it, enlist your network of vendors that you have. Talk to your EMR people, talk to your IT people, because everybody has solutions for this. And I think there's a lot of help out there where you can do it, and there's not always a big price tag to it either. You probably have a lot of solutions right at your fingers that you may not even know you have.
Thanks, Wiks. And I think before we turn it over to the Q&A session now, the one thing that I did want to mention is that, to Arielle's point, not all telemedicine practices, not all telemedicine platforms are built alike. Some can get you into quite serious, criminal exposure even. So my question is to Arielle, how difficult is it for you to do that due diligence to find out, I guess, where the money came from, or whether that's difficult? Is that something that, practice can come to you, present you their agreement, and then as part of your review and due diligence, it comes up as a red flag? Or, how deep dive do you need to take to find out?
Sure, and really that can be done with whatever information the practice has available. So if a provider is looking to get involved in a model and they don't necessarily have a contract yet, and they've just had sort of initial discussions with a company, and it's more of that second example that I referenced, where a telehealth company is actually paying the physician versus a physician incorporating telehealth into their existing practice. There's simple questionnaires that we've developed in the past that can be provided to these companies to elicit all the information that we would need in order to make an assessment of the regulatory risk. And that's before really even diving into the specifics of those potential problems. Usually it's pretty clear just by simple yes or no answers to a series of 20 or 30 questions whether or not something is a little bit sketchy, for lack of a better word, and that the provider needs to be aware of it before they move forward and invest additional legal expenses or other resources in attempting to participate in one of these models that's going to end up exposing them to, as you mentioned, not only civil liability but also potentially criminal liability.
Thanks, Arielle. I don't know, Lauren, if you have any other questions.
I do actually have one question here. So we're a small practice without a lot of resources. What are some very basic steps we can take to put together a telemedicine program?
Do you mind if I jump on that one, Guillermo?
Please do, Wiks. Yeah.
Great. So that's a really good question, because the type of program that your small practice or even medium-sized practice going to look a lot different than RWJ Barnabas or Hackensack or even an organization that has 25 or 50 physicians. I would say, to get started, and if you do nothing else, and to put yourself in a proactive, defendable position, look at writing up your policies and procedures, and then making sure that all of your employees are trained. From there, you can do lots more, and you can start following the 7 elements of compliance and really build a robust compliance program. But to at least just establish your platform to show that you haven't put your head in the sand, and that you've trained your employees and you guys are all aware of it, that's a great first step in the right direction.
Great, thank you. I don't see any other questions at the moment. So if anyone, or do any other speakers have anything else to add? Or if not, we'll conclude it. And please feel free to reach out to us to continue the conversation. We have all of our contact information here, and we will be sending around a copy, a recorded version of this program for all of you.
Yeah, if anyone has any questions, please, don't hesitate to reach out to us. We're here to help. We understand that, there's a lot of transition that's happened in the last year, and, there's more guidance to come. There's, audits to come, unfortunately, and, we're here to be a resource for you so that you can continue to do what you do, which is, help out your patients. So thanks to everyone.
Thank you all for attending today.
Thank you.